The BMD Podcast, anytime you want. Hey everybody, welcome back to the channel. You know me, I'm the BMD, your host on Major League Broadcasting, MLB in the short form. We are so happy to have an honored guest here on talking about an unusual subject, and that is genetics. We all have it, commonly known, slang on the street, DNA. Everybody say hello to Justin Lorentz. He is a genetic counselor out of Sunnybrook Health Center, Sunnybrook Hospital. Good afternoon, good morning, good evening, sir, somewhere in the world.
How are you?
Good. So listen, a little bit of background because it's probably not an awkward topic, but a topic that doesn't get a lot of play, press, and airtime, and we're about to do that today. We're going to put you, sir, on the map. That's our job, and I think it's a wonderful, wonderful topic. So a little bit of background about who is Justin Lorentz.
All right, so I am a genetic counselor. I kind of started doing genetic counseling. Well, I guess we kind of get trained out of a graduate degree that specializes in genetic counseling. And it's a 2-year degree where you learn a lot of theoretical stuff and then you also practice clinically. And so all of these programs are based out of hospitals. And they teach you how to do all the different forms of genetics in terms of human medicine. And then once you graduate from a program like that, you move into a field of genetic counseling, typically. And for me, that meant being at Sunnybrook. I've been there for 8 years.
So your background on your theory studies was it McGill or McMaster?
Yeah, I went to McGill.
Okay, and you got a master's degree there in biology and genetics?
So the undergraduate degree varies. My undergraduate degree is from University of Waterloo in molecular biology. And then, which is the study of DNA and proteins and all the stuff that you can't see that's involved in biology. And then your graduate degree, my master's degree, is specifically in genetic counseling.
So what is a genetic counselor? Why isn't it Dr. Lorentz? Why isn't it master degree in everything, doctor? I got really thrown when your bio talks like doctor, but I only see genetic counselor.
Yeah, we're only genetic counselors.
You got a lot more smarts than that. Give the viewers and listeners a breakdown on that separation. We interviewed a fellow colleague of yours, Dr. Vesprini, and it was Dr. Vesprini, but it's Justin Lorentz, genetic counselor. I'm confused.
Yeah, well, he probably happily goes by Danny Vesprini, but yeah, you're right. He's formerly Dr. Vesprini. So, all medical doctors have to go to medical school. They become doctors, and then they'll specialize into the field that they want. And so that actually happens in the world of genetics too. People will be doctors, and then they specialize in genetics, and they're called geneticists. And after going to med school, they do a specialty. Man, I think it takes up to 4 or 5 years of them just learning everything about human genetics. And these are typically the physicians who sign off in the most traditional sense of the field of human genetics. Geneticists are the ones who sign off on test results. A genetic counselor, we are medical professionals who are trained specifically in human genetics. We're not physicians, and so one of our limitations to what we can and can't do is signing off on actual genetic tests. All tests need to be signed off by a physician. And so in certain special fields of medical genetics, particularly in cancer genetics and maybe cardiac genetics, You don't need a geneticist to sign off on those reports. An oncologist like Dr. Danny Vesprini or a cardiologist can sign off on those reports. And so we are basically facilitators of genetic testing. We give people informed consent, but we don't bear the responsibility of ordering kind of test results at this time. Some parts of that may change in the future, but at this point in time, that's the status.
So why this field of medicine, research, investigation? What turned your crank to follow into that line? And I know the overtone is a breast cancer, male female overtone, along with male prostate. Why that interest in those areas?
Yes, those are all kind of good questions. And so, I mean, typically when people study science and genetics and biology, they are interested in working in labs. And, we're being a researcher working in a lab with pipettes and test tubes and everything is kind of what we think of. And then some people, as they get experience in lab, wonder, hey, I want to be working with people. I want some more interaction. And so genetic counseling is kind of this merger of this science, hard science of genetics, and also working with people, explaining concepts. So that's kind of how people move into this field to start thinking about pursuing that as a career option. Now, when we start specializing, some people work in pediatrics, some people work in prenatal, people who are considering having kids or who have kids, or are pregnant, and there might be medical issues with the pregnancy. And then there's other specialties like adult genetics, where cancer fits in. And so I applied for, I knew a genetic counselor who actually worked at Sunnybrook. I got in doing a very, very small task for a short period of time that evolved into a permanent position. And then I specialized even further to work in prostate cancer genetics with Dr. Danny Vesprini, because he has interest in genetics. And it was kind of I was at the right place at the right time, and I had an excellent mentor who was able to kind of allow me to learn more and start some research initiatives in the field of prostate cancer.
So are you the first guy, not you as the first guy in the field, but are you the first guy that starts to take apart the family tree on finding out predispositions, medical perhaps, what happened, forefathers, foremothers, who carries it from the mother, who might not get it from the father? I'm just winging this, but do you do the setup on taking apart the family tree to find out where it's coming from, and future generations could be predisposed on medical conditions from our ancestors?
Yeah, you got it. Looking at family histories is the key kind of medical tool that we use when assessing families and trying to really figure out what's going on. So I guess one of the most important concepts with all of this, with respect to genetics, is that most, when looking at things in the field of genetics through the lens of cancer, most cancers are not because or caused due to a single mistake in a single gene that's passed on from one generation to the next to the next. We call that hereditary cancer. Most cancers aren't hereditary. Most cancers happen by chance, by bad luck, or by multiple genes and environmental factors all kind of coming together in ways that are too complex for us to understand. We call that multifactorial. The minority, 5 to 10%, are hereditary, are passed on from one generation to the next. And so my job is to distill, hey, based on family history, is there something hereditary going on, or is there something multifactorial, maybe non-hereditary, maybe what we call sporadic? And then if I think it's hereditary, then we start saying, okay, well, if it is looking like it's coming from one generation to the next, or there's some things that are indicators of hereditary cancer, who's the best person for us to test? And if we can find a gene mutation in one person, maybe we can explain why cancer happened in other people, and maybe anticipate who might be at risk for cancer given their genetic test results.
So do you do the setup for the doctors that request your expertise on giving them a path of perhaps diagnosis further or cure?
Yeah, so I mean, we work in the field of cancer. Genetic counselors tend to be the experts in the field. The physicians that they work with are really good at treating cancer in their specific ways. We're really good at understanding kind of underlying genetic causes that predispose people to cancer. In the past, our job was kind of figuring out why cancer happens. If we can figure out why cancer happens in one individual, it might help doctors manage that person differently in terms of treatment, but it can also help other family members. More recently, the treatment arm of this whole cancer genetic story has become more important, particularly in the world of prostate cancer genetics, because there are certain drugs that can target cancers that are caused by certain hereditary gene mutations. And so now there's a lot of doctors saying, hey, I want to know whether or not my patient has one of these gene mutations because I might offer them this medication, or I might suggest that maybe they're a better candidate for surgery rather than radiation, depending upon the conversation, depending upon the situation, depending upon the gene.
What about altering DNA, or are you born with it and your imprinting's done?
Yeah, and so some aspects of genetics now already seem pretty sci-fi for us to be able to understand why someone gets cancer based on a genetic component. That was probably something that seemed a little bit sci-fi at one point in time, and now we're there. Yeah, the next piece is changing genes. So this is a CRISPR technology where you have a gene mutation, and maybe we can modify those genes and cure people of a genetic condition. The issue is that these gene mutations are inherited. They're present in either the sperm or the egg that got fertilized to make us who we are. Therefore, that gene mutation is present in every single cell that we have. And so the process of changing these genes can be quite intricate. The first organs that will start getting genetic treatment to change their genes are going to be organs that can easily be accessed. And right now, the target is going to be eyes. So people who have ocular genetic conditions that maybe increase risk for blindness or cause blindness, they might be doing therapies on the eye, maybe through eye droplets, that might be able to change those genes. And so when we start seeing advances in ocular genetic conditions, that's going to set the stage for genetic advances in other organ sites, including prostates, breasts, pancreases, who knows what.
So it sounds almost sci-fi, Star Wars, Star Trek, aliens, UFOs. Like, where is your field going? Obviously, other than up, but where is it going? It seems like you're busting at the seams on new ways of potentially treatment, or the person, let's say, I'm not a doctor, of course, the women that have that bad breast cancer gene, I forget the name of it, where they're born with it. And Angelina Jolie had it. She removed her breast to try and take that out. And I know she has 2 or 3 daughters. Are they going to get it? Do they have to remove their breasts? Or tell the listeners and the viewers, if you have the death gene, whatever it is, do you start early? Tell us about testing, marketing of testing. It's testing. Sunnybrook, I know one of their byline and preachings is if we are able to test it early, we have a greater chance to cure it better.
Yeah, so let's start with Angelina Jolie. The death gene. It's an interesting way of putting it. Yeah, but we call individuals who have these gene mutations, we call them previvors. They are survivors of a predisposition to cancer. And so having that gene mutation doesn't mean you're going to get cancer. It means your risk for cancer is elevated. And Angelina Jolie has the BRCA1 gene mutation. This greatly increases risk for breast cancer and ovarian cancer. Knowing this information, she chose to have her breasts removed and have reconstructive surgery. In Ontario, this is offered to all BRCA1 and BRCA2 gene mutation carriers. It's covered under OHIP. And that reduces risk for breast cancer by up to 90%.
Wow.
Risk for ovarian cancer can be greatly reduced by having ovaries removed. And Angelina Jolie did this as well. And so I don't expect Angelina Jolie to ever get breast or ovarian cancer, even though she is a BRCA1 mutation carrier. Wow. And her mom ended up passing away from ovarian cancer, and that was the person who kind of brought this all to light. And so some people have that family history that allows them to learn this information to, as you said, understand what their risk is early and maybe even prevent cancer from happening in the first place.
So females seem to be staggered and, certainly not blessed, but cursed. That's the word I was looking for, with the breast on the anatomy. And the male side, it seems to be prostate. I asked Dr. Vesprini this. Perhaps I'd like to hear your opinion too. Why between the sexes are those organs targeted? Like, are we born weak in that anatomy, or I don't know. Is it because with the women through the pregnancy, maybe breastfeeding, and the males with maybe kidney stones or gallstones, or I don't know. What is the issue on the male, female? Why are those two organs seem to be in the anatomy of the human body seem to be cursed?
Yeah, I know. Yeah, these sex organs are cursed, and so it's funny because
is it lack of use?
So we could get into some studies with respect to prostate cancer and
right.
use and lack of use. And so, I mean, some people will refer these as sex organs, and they kind of are. Maybe the prostate is more than a breast, but men have breasts too. The thing about cancer is that we know estrogen is an excellent, beautiful hormone. It makes people, it makes humans what humans look like today. There's a lot of great things that estrogen does, but estrogen's also carcinogenic. The more exposure you have to estrogen, and women have to estrogen, the higher the risk for certain cancers, and primarily breast cancer. Same thing is true for testosterone. Testosterone can be a driver of certain cancers, and in this case, prostate cancer. And so one thing that these two organs have in common is that hormones definitely influence cancer risk in these two organs. But BRCA1 and BRCA2, we see these higher rates of breast cancer and prostate cancer and mutations in these genes, but we also see increased risk for pancreatic cancer. BRCA2, we see increased risk for melanoma. And then we see in women ovarian cancer risk. And so could there be, I think it's overall the kind of estrogen, testosterone can be drivers in the breast and prostate side of the story. And maybe that is the connection between the two. In terms of use, there's one study that showed that for prostate cancer risk, one way to decrease risk for prostate cancer is to ejaculate under the age of 40 more frequently. And so those who ejaculated more under the age of 40 had more of a protective effect for prostate cancer. And so some of my patients will say, hey, great, well, tell that to my wife. And I'll say, hey, it's an ejaculation, it's not sex. And so it's a completely different thing. And it only applies under the age of 40. And a lot of men that I speak to are a little bit older than that.
Do you believe that stat?
I do, yeah.
Is it fake news, to coin a phrase?
No, I believe that stat. Yeah, the data that comes out of it, I think, or the study that conducted this data is a reputable study. However, when it comes to things like this, it's hard to study. How do you monitor and validate how often someone is ejaculating? It's a self-reported thing. And so, how much stock and store do you put into it? I think that it sounds reasonable to me. The evidence, in how the study was conducted is reasonable. But if you're depending upon people's opinions, then that could be the flaw in the data collection.
You see the ads on TV, hear them on radio that, early detection cure. I've heard breast cancer now could be on early detection for cure, could be as up into the 90% as prostate. Then I hear, chances are you won't die from prostate cancer. You'll die from something else. I've always wondered, if you have prostate cancer, is there a link to it moving to other organs genetically, or when your cancer is at the prostate removed, chemo, radiation, whatever the treatment is, surgical, are you really cured? Or what about the one gene that didn't get, lifted up in the central vacuum machine? And that one gene has remained floating around inside you? Does it go from the prostate right over to your kidney or your pancreas, as you mentioned? Maybe talk about the central vacuum cleaner on getting all the genes.
Yeah.
The bad genes.
Yeah. So when it comes to prostate cancer treatment and outcomes based on how someone was managed for their cancer, that leaves my realm of specialty and expertise, since that's where the Dr. Vesprinis of the world can provide their kind of.
But you have an opinion. You have an opinion.
But when it comes to, for example, if someone a man has prostate cancer, he has a gene mutation, let's say it's to the gene BRCA2, which we know increases risk for aggressive prostate cancer. And that man gets his prostate cancer removed early, and all of his 5 years later, there's no recurrence or look like there's anything kind of happening in the prostate story. What about his pancreas? What about his breast tissue? And so all men with BRCA2 gene mutations have that risk for prostate cancer. They also have up to an 8% lifetime risk for male breast cancer. And they have maybe up to an 8% lifetime risk for pancreatic cancer. And so prostate cancer aside, these are now things that we also have to think about. These are what we call second primary cancer. So a new cancer at a different site, completely unrelated to the prostate and completely unrelated to outcomes of the prostate cancer surgery. And so it goes back to that point where with these gene mutations, you're born with them. They're present in every cell in your body, but only certain organs seem to really be impacted. In the case of BRCA2, for men, it tends to be male breast tissue, pancreatic tissue, prostate tissue, and then perhaps skin tissue. We think that there might be an increased risk for melanoma as well.
So are we making headway in your field, because we're talking with you today, are we making breakthroughs on, I don't want to say treatment, but data, the research on how we can stop this dreaded word cancer and this plague that is just ripping up the world? You can't walk out and talk to your neighbor and within 5-10 minutes, Joe Blow's got cancer, Sarah's got cancer. Like, will we ever throw it away? Is it lifestyle? Is it diet? Is it, where are we going with this plague?
Yeah. And so, I think it's interesting that you use the word plague for that, because back in the day, cholera was the plague, and people were dying from these infectious diseases. And then we got a cure for that. And then, heart disease became the plague. And then we started being able to give people medications for that. And then people started living longer, and now cancer is the thing. And so it's almost like, if we cure cancer, what's going to get us next? What will be the new thing?
That's my question.
Yeah. And so the thing about cancer is that human bodies were never meant to live to be 100 years old. That was never part of the deal as we were evolving. Maybe we'd live to be 30 or 40. And people getting cancer in their 30s and 40s is pretty uncommon. And so we're already stretching the limits of what evolution kind of thought was going to be part of the human race's story. And if anybody lives long enough, they should eventually get cancer, because cancer is an accumulation of genetic mistakes and mutations that we get by existing on this planet, being exposed to radiation either from the sun or maybe even from the earth. Who knows what else is being bombarded and thrown at us that's mutating our cells. And all these healthy, perfect cells that we had when we were born start accumulating mistakes throughout life. And eventually we get the wrong mistakes and the wrong genes. That cell may go down this trajectory of becoming cancerous. So I don't think that we'll ever cure cancer, but what we will get better at is our way of identifying cancer early and then treating cancer early. And as long as we still live in a society where we have the means and technology to do these things, then that population who's able to access all of that stuff will do pretty well. And so I guess the story now is trying to figure out ways to do exactly that: screen, detect cancer early, and then treat it early.
We've got about just under 3 minutes left in the show. Want to ask you 2 questions. I noticed on your bio it was Genetic Justin on your Twitter handle.
Yeah.
How did that come about? I know the obvious, but how did that come? Because it's catchy.
Yeah. like just in time. There's lots of plays that you could do on with Justin. I was in grad school at that time, and I was interested in Twitter because that was kind of a new thing. And getting professional organizations such as genetic counselors and the Canadian Association of Genetic Counselors online in that social media realm was important. And so one of my first kind of takes to social media through Twitter was to kind of do it under this realm of starting up a conversation and exploring the realm of genetics in social media. And so that's where that came about.
Gotcha. Listen, how can people connect with you? If you can and you're allowed, please give out your social media IDs if they want to take this farther. In the world I live in, you never know who's listening and watching. And we do these shows and interviews to try and help people that may be in the box or feel cornered and want to come out of the closet. Lots of people don't want to admit they've got a problem. How can they connect with Genetic Justin?
Yeah, so I have that Twitter account, and I also pretty Googleable. If you Google, I work at Sunnybrook, and if you Google Justin Genetics Sunnybrook, you'll have my genetic email, which should be available my Sunnybrook email, which should be available as well. And so I can be reached either probably on Twitter, although I'm not as active as I probably could be, or on my professional email, justin.lorentz@sunnybrook.ca.
Well, listen, we're out of time. I hope you enjoyed our session. I hope you'll come back on again in maybe a few months, 6 months or something, with some updates on telling us some challenges you're having, and maybe come up with more data, more investigation, research, and cures. And you and your family have a wonderful Christmas and a happy New Year. Folks, you've been listening to me, the BMD. I'm the BMD and you're not, but we have had Justin Lorentz on. He is a genetic counselor at Sunnybrook Health Services Hospital, if you will. And we're glad to have him on, of course. And you've been listening to Major League Broadcasting on our YouTube channel. You know what we tell everybody? If you're happy, tell a friend. See you next time.